Dr. HARSHUL Tak, our young, bright ophthalmologist from Jaipur, founder of Rawat Eye Hospital. Dr. HARSHUL is not only an efficient and skilled eye surgeon, but you've seen his extracurricular life beyond ophthalmology, how he's got people on to doing different things. So we call him the Virat Kohli of ophthalmology world, doing everything, surgery, sports, you name it. So he's going to be talking about how to deal with astigmatism patients in presbyopic IOL forum.
Good morning, everybody. At the outset, I'd like to thank Dr. Parul for making me a part of her wonderful course. So I'll be speaking on how to manage astigmatism along with presbyopia. How do you plan for astigmatism correction while doing cataract surgery? So Dr. Parul nicely showed all the options which are available for trifocal and EDOF IOLs. But we all know that treating preoperative corneal astigmatism is crucial for patients with trifocal IOLs because it has been reported that if we have residual astigmatism more than 0.75 diopter, it leads to deterioration of visual quality. Of course, subjective perception of halos and glare after multifocal IOL is correlated with the amount of the post-operative residual astigmatism. So recently we have availability of trifocal toric IOLs which compensate for different level of pre-existing corneal astigmatism after cataract surgery. So the studies have shown that toric version, they not only distribute incoming light into 3 foci as in the trifocal IOL, but also simultaneously they compensate for the flattest and steepest meridian of the cornea in these 3 foci. So whatever presbyopia correcting technologies we use, if we don't address this astigmatism, patient will not have satisfactory uncorrected vision and spectacle independence after surgery. So as Dr. Rishi mentioned that before going for any these premium IOLs, multifocal, trifocals, it's very important that firstly we manage and stabilize ocular surface, especially if patient has dry eyes or if patient has pterygium. So we need to take care of that ocular surface before going ahead because all the measurements, they become affected because of these corneal conditions. So to accurately measure corneal astigmatism, of course, we need optical biometers. So we have plethora of optical biometers right now available with us, OA2000, IOL Master 700 or Anterion or Lenstar, whatever you decide. But biometry is the key and it has to be accurate. So axial length, of course, as Dr. Abhijit also mentioned, that if you don't have optical, at least you should use immersion biometry, and if you have optical biometers, it's good. So coming to keratometry, keratometry is the main important measurement to calculate the toric IOL which is required to correct astigmatism. So we can always enhance accuracy of toric IOL calculation by taking multiple measurements. So we should try to employ at least 2 devices which are based on different principles. Like if you use the AutoK, you try to use Scheimpflug based or the optical biometers. It will definitely increase the accuracy and we should have consistency in the readings whatever we are taking. And whatever keratometry you are doing, do it before you put any drop over the cornea. So a word about posterior corneal astigmatism, which is, as Douglas Koch showed in 2013, the importance of posterior corneal astigmatism, which plays very important role. We all should know that the posterior steepest meridian is almost always vertically aligned. So what it does is, it creates an against the rule astigmatism. So if we are measuring with the rule astigmatism, we need to undercorrect, and if we are treating against the rule astigmatism, we need to overcorrect. So if you look at this slide, it clearly shows that the anterior corneal surface, it behaves as a plus lens. Anterior cornea can have with the rule, against the rule, or oblique astigmatism. And with age, it changes from with the rule to against the rule. But posterior corneal surface, it's almost always against the rule. It behaves as a minus lens, and it stays against the rule with age. So coming to the toric IOL calculation, so once you have the flat and steep case, so the toric calculator, Barrett toric calculator, it has proprietary like mechanism to compensate for the posterior corneal astigmatism. So you feed in the flat K, steep K in the calculator. If you can see here, this patient had 44 K at 180 degree and 46 at 90 degrees. So patient had with the rule astigmatism of 2 diopter. But if you look at the final calculation, it shows that patient should receive a toric IOL which corrects 2.25 at IOL plane and 1.5 diopter at corneal plane. So it has come down from 2 diopter, which was with the rule, if you look at the anterior cornea, only to 1.5 diopter. So whenever we have with the rule, we need to undercorrect, and if we have against the rule, we need to overcorrect. So this is a very good slide from Dr. Savini's studies, which showed the how we can calculate the total corneal astigmatism using the Scheimpflug technology. This is a slide which shows that if we use only SIM-K, that is only the anterior surface corneal astigmatism, with the rule, we tend to overcorrect, and against the rule, we tend to undercorrect. But if you use the total corneal refractive power, the results are very good and near to ametropia. So after accurately measuring the keratometry and axial length, now we need the IOL power calculation formulas so that we can get the magnitude of IOL power, the toricity and axis. So the Barrett toric calculator works wonderfully in almost all the cases, so which is freely available online, and all the biometers of course have incorporated Barrett toric calculators. It takes into account both the effective lens position and posterior corneal astigmatism. So these are the different IOLs, trifocal toric IOLs which are available, like Restore, Technis, Symphony, Physiol, AT Lisa. So all the trifocal, multifocal IOLs have incorporated astigmatism along in their models. So coming to the methods of toric IOL alignment, first we need to do, either we can do manual marking of the cornea for reference axis, we can use slit lamp or bubble marker or pendulum marker, or we can use nowadays image guided systems which are Varion and Callisto, or we can also use intraoperative aberrometry like Aura and Holos. So coming to how to use the slit lamp to mark the reference axis. So patient is sitting straight on the slit lamp. We narrow down on the, tilt the slit beam horizontally, narrow it down. And now here I am putting scratch marks with 26 gauge needle on both the sides on the epithelium. So once you have these scratch marks, then you go and stain these scratch marks. So even if your ink fades, these scratch marks, they remain for 2-3 hours, and you never lose your reference marks there. So this is the 0 and 180 reference marks which have been made. And this is how we just, again I use a 26 gauge needle to mark the, so this is the steep axis where toric IOL needs to be aligned. So this is a hydroimplantation technique which I love to use, and it has advantage that there is no OVD left behind which can cause toric IOL rotation. So this irrigation cannula maintains anterior chamber depth nicely and capsular bag. You just put the leading haptic and optic in the bag and put the trailing haptic in capsular bag. So once you have the IOL in the bag, you need to make sure that you have the perfect sizing of the capsular axis, which is very crucial for effective lens position and also for long-term stability of the IOL. So here the overlap was a bit more, so I go ahead and enlarge the axis on one side. And once you have the perfect sizing, you can rotate the IOL to the final desired axis, and you can see it's aligned well to the steep axis where it's needed. And after that, you hydro stitch all the wounds, and make sure that once you take off the speculum, you keep on seeing that there is no rotation of the toric IOL. This finishes the case. So to conclude, now we have devices that calculate total corneal astigmatism, so we can make more precise measurements and we can achieve target emmetropia closely. Thank you very much.
Thank you, Harshul. That was a wonderful talk and very good videos.